Okay. Let's dive into nipple discharge.
Oh, yeah.
It's a common concern that walks into GP offices every day.
Every day. Yeah.
We've got some new research.
Great.
I'm excited to unpack it
Me too.
with you.
Yeah, it's definitely one of those symptoms that
Yeah.
can make both patients and doctors
Oh, yeah.
kind of raise an eyebrow.
Yeah.
The good news is that
Yeah.
with a solid approach, you can assess these cases efficiently and confidently.
You know, it's fascinating to me that up to 80% of women experience nipple discharge at some point.
Wow.
But so many are unsure what's normal and what's not.
Right, and that's where our depth dive comes in.
Okay.
We're going to break down the different types of discharge.
Okay.
We'll highlight those red flags.
Yeah.
You need to watch for and walk through how to evaluate and manage these cases.
Excellent.
Yeah.
So to start, I see from the research that nipple discharge is generally categorized into three main types.
Okay.
Lactation,
Yeah.
physiologic discharge, and pathologic discharge.
Okay.
I imagine lactation is the most straightforward, right?
Yes. Lactation is simply the normal production of milk or colostrum.
Okay.
It can persist for several months after breastfeeding ends,
Yeah.
which is something to keep in mind when a patient presents with this symptom.
So no need to jump to conclusions if new mom is experiencing discharge even after she stopped nursing.
Exactly. Now, physiologic discharge,
Oh.
also known as galactorrhoea,
Yeah.
is where things get a bit more nuanced.
Yeah.
This refers to discharge
Yeah.
that's not related to pregnancy or breastfeeding.
What are some of the things that can trigger this type of discharge?
Well, often it's linked to something called hyperprolactinemia,
Oh, okay.
which is an excess of the hormone prolactin.
Right.
This can be caused by certain medications, pituitary tumors, or other endocrine issues.
Oh, wow.
But we also see cases of physiologic discharge
Yeah.
that are idiopathic,
Okay.
meaning we can't pinpoint a specific cause.
So getting a detailed medical history, including medications, is key in these cases. Yeah. Is there anything specific about the appearance of physiologic discharge that can help us differentiate it from other types?
Yes, good point.
Okay.
Typically, physiologic discharge is milky and bilateral,
Okay.
coming from multiple ducts.
Uh-huh.
However, it can sometimes be unilateral,
Okay.
or even present in other colors, like yellow, green, brown, or gray.
Interesting.
Yeah.
But if we see bloody discharge, that's a clear signal that we need to dig deeper.
Right. Absolutely bloody discharge.
Yeah.
Along with being unilateral and spontaneous
Right.
are major red flags that
Okay.
point towards pathologic discharge.
Right.
And, of course, any discharge associated with a breast mass or skin changes, especially in women over 40, should be taken very seriously.
Okay. Those red flags are definitely important to remember.
Yeah,
So we've got these three main categories.
right.
What are some of the most common culprits behind pathologic discharge?
The research points to intraductal papillomas as the most frequent cause, accounting for over half of cases. These are benign growths in the lining of the milk duct.
Okay.
And while they can cause bloody discharge,
Yeah.
it's important to note that a small percentage of them can harbor atypical cells or even ductal carcinoma in situ,
Oh, wow.
DCIS.
So even when a papilloma is the cause, we can't completely rule out more serious concerns.
Right.
What about other causes of pathologic discharge?
Another common one is ductictasia,
Okay.
which is essentially a dilated milk duct. This
Yeah.
is a benign condition
Yeah.
that can cause sticky discharge and sometimes inflammation.
Okay.
And then, of course, we have breast cancer,
Yeah.
which, while less common, is always a possibility we need to consider,
Right.
especially in older patients.
It seems like evaluating nipple discharge involves a lot of detective work.
Yeah.
What are the most important things to consider when a patient comes in with this concern?
As with most things in medicine, it
Yeah.
all starts with a comprehensive history and physical exam.
Okay.
That's where we gather those crucial clues
Right.
to guide our next steps.
Let's talk about the history first.
Okay.
What specific questions should we be asking our patients?
The characteristics of the discharge itself are crucial.
Okay.
The color, the frequency, whether it's spontaneous or provoked unilateral or bilateral,
Right.
and whether it comes from a single duct or multiple ducts.
Okay.
This helps us differentiate
Yeah.
between physiologic and pathologic discharge.
So we're essentially building a profile of the discharge
Exactly.
to see if it fits the pattern of something more concerning.
Precisely. Then we need to dig into their medical history.
Okay.
Any recent breast trauma,
Yeah.
including mammographic compression,
Okay.
history of amenorrhea or symptoms suggesting hypogonadism,
Right.
and a detailed medication list.
Okay.
Some medications can trigger hyperprolactinemia
Uh-huh.
or even cause blood discharge.
So we've gathered all this information.
Right.
What does a thorough breast exam entail in these cases?
First, we're visually inspecting the breasts. For asymmetry, skin changes, nipple position, any scars, and vascular patterns. Then we palpate for masses, tenderness, and enlarged lymph nodes.
Right.
And of course, we attempt to elicit the discharge ourselves,
Yeah.
noting the location of the involved duct or ducts.
I imagine good lighting and magnification are essential for this.
Absolutely.
Okay.
You want to be able to get a clear view of the nipple and surrounding area.
Right.
And if you can't elicit discharge initially, applying a warm compress to the breasts sometimes helps.
Okay, so we've taken the history disseminated, done a thorough exam,
Right.
and now we have a better sense of what we might be dealing with.
Yeah.
What's next in the diagnostic process?
This is where our approach diverges,
Okay.
depending on whether we suspect physiologic or pathologic discharge.
Let's start with physiologic discharge,
Okay.
which we've established is usually benign.
Right.
What kind of tests are typically ordered?
For women of reproductive age, we start with a pregnancy test.
Okay.
Then we check prolactin levels.
Yeah.
If those are elevated.
Uh-huh.
We investigate further with renal and thyroid function tests
Right.
to look for potential underlying causes of hyperprolactinemia.
And if everything comes back normal and the discharge is idiopathic.
Then reassurance and observation are often the best course of action.
Really?
Transient idiopathic galactorrhea,
Yeah.
especially in younger women,
Uh-huh.
is usually self-limiting
Okay.
and doesn't require aggressive intervention.
That's good to know. But for pathologic discharge, things get a bit more serious, right?
Yes, when we see those red flags, we typically bypass the lab tests
Okay.
and move directly to imaging. That's right, when we have those red flags pointing towards a pathologic cause, imaging becomes our primary focus.
So let's talk imaging.
Yeah.
What are the go-to modalities
Sure.
for evaluating pathologic nipple discharge?
Okay.
I know mammography and ultrasound are often mentioned.
Right.
Is it a matter of choosing one or the other?
While both are important, the choice and order really depend on the patient's age. Remember, the risk of malignancy goes up as women get older.
Okay, so age plays a big role.
Right.
What's the recommended approach
Okay.
for different age groups?
For women 40 and over, we recommend starting with both a diagnostic mammogram and a targeted breast ultrasound.
And for women under 40?
Between 30 and 39,
Okay.
we typically begin with a diagnostic mammogram. We proceed to an ultrasound if the mammogram findings warrant it,
Okay.
or if there are other concerning factors.
What about even younger women under 30?
In that age group, ultrasound is usually the preferred first step.
Got it.
Mammography is reserved for cases where the ultrasound shows something suspicious, or if the patient has a strong family history of breast cancer.
Now, we talked earlier about how men have a higher risk of malignancy when they present with nipple discharge.
Right.
Does that change our imaging approach for them?
Absolutely. For men with pathologic discharge, regardless of their age, we recommend both a mammogram and an ultrasound.
Okay.
It's better to be thorough given the higher likelihood of cancer.
That makes a lot of sense. Let's dive a bit deeper into these imaging modalities.
Okay.
I know they each have their strengths and weaknesses.
Right.
Can you walk us through those?
Sure. Mammography is excellent at picking up calcifications and masses, but it can sometimes miss small lesions,
Yeah.
especially those that are not calcified
Okay.
or are located within the ducts.
Right.
Ultrasound, on the other hand, is really good at visualizing dilated ducts and any nodules inside them.
Okay.
It can detect lesions as small as 0.5 millimeter.
So ultrasound can sometimes catch things that mammography might miss.
Exactly. Ultrasound has a higher detection rate for lesions that aren't visible on mammography.
Right.
However, it's also less specific,
Okay.
meaning it's not as good at distinguishing between benign and malignant findings.
So each modality has its pros and cons.
Right.
We often need to use them together to get the most complete picture.
Exactly.
But what happens if both the mammogram and the ultrasound come back normal, but we still have a strong suspicion that something's not right? What are our options then?
In those cases, we might consider a breast MRI.
Okay.
It's a highly sensitive imaging modality,
Okay.
meaning it's very good at finding abnormalities. But the trade-off is that it also has lower specificity
Okay.
and can sometimes flag benign findings,
Right.
which can lead to more biopsies.
So a breast MRI is a powerful tool, but we have to use it judiciously.
Right. There are also a couple of other less commonly used imaging techniques that I want to mention.
Okay.
Galactography,
Yeah.
which is also called ductography, and
Yeah.
ductoscopy.
Okay. I'm curious about those. Can you give us a quick rundown of how they work and when they might be helpful?
Galactography involves injecting contrast material into the discharging duct
Okay.
and then taking a mammogram.
Ah.
It helps us visualize any blockages or filling defects within the duct.
Right.
Ductoscopy uses a tiny endoscope
Okay.
to see directly inside the duct.
Those sound quite specialized. Are they routinely used for evaluating nipple discharge?
Not really. They're less widely available
Okay.
and can be technically challenging to perform.
Yeah.
Also, any lesions found using these methods would require surgical excision for diagnosis, as we can't biopsy directly through them.
So they're more like niche tools reserved for specific situations.
Yeah.
Before we move on to treatment, I want to ask about cytology.
Okay.
Is that something that's typically done when we're working up nipple discharge?
Actually, cytology of nipple discharge isn't generally recommended.
Okay.
The research shows it's not very reliable and doesn't really change how we manage the case.
So we can usually skip the cytology. What about biopsies? When are those necessary?
Biopsies are essential if we find something abnormal on imaging.
Okay.
An image-guided core needle biopsy is the gold standard for getting a tissue diagnosis, which is crucial for guiding treatment decisions.
And what if there's a suspicious-looking skin lesion on the nipple?
A skin punch biopsy is definitely warranted in those cases,
Okay.
especially if the lesion resembles eczema or dermatitis.
Right.
We need to rule out Paget's disease,
Yeah.
which is a rare type of breast cancer.
Good point, now that we've thoroughly covered diagnosis.
Right.
Let's shift gears and talk about treatment.
Okay.
As you mentioned earlier, the approach will vary depending on whether we're dealing with physiologic or pathologic discharge.
Exactly. Let's start with physiologic discharge.
Okay, so for physiologic discharge, what are the main management strategies?
The first step is to address any underlying cause, like hyperprolactinemia.
Right.
If we find one, that might involve adjusting medications or other therapies to manage the condition.
What if the discharge is idiopathic and we can't pinpoint a specific cause?
In those cases, reassurance and observation are usually the best approach.
Okay.
Transient idiopathic galactorrhoea, particularly in premenopausal women, often resolves on its own without any intervention.
So no need to jump into aggressive treatment for those cases.
Right.
But with pathologic discharge, things are a bit different, right?
Yes. When we're dealing with pathologic discharge, surgical management is often the preferred route after a thorough evaluation.
Okay.
The specific procedure will depend on the imaging and biopsy results.
Right.
And the extent of the surgery is always tailored to the individual patient's situation.
It seems like there's a lot to consider when it comes to surgical management for pathologic discharge.
Yeah,
Maybe we can dive deeper into that in the next part of our deep dive.
absolutely. There's a whole world of surgical options and techniques to explore.
Yeah.
And we can unpack all of that in our next segment.
Sounds good. But before we get there, are there any special considerations we should touch on? Like pregnancy and lactation? We haven't really talked about those scenarios yet.
You're right. Those are important to address.
Okay.
Nipple discharge during pregnancy and lactation can be a bit more complicated to interpret.
Right.
For example, bloody discharge during pregnancy is usually benign
Okay.
due to increased blood flow to the breasts.
Right.
However, if it persists further, investigation is definitely needed.
So close monitoring is key during pregnancy.
Right.
What about lactation?
Okay.
Are there any red flags there?
Bloody discharge in the early days of lactation is actually quite common
Okay.
and typically resolves within a week.
Uh-huh.
But if it continues beyond that,
Okay.
we need to look into it further.
Okay.
Essentially, it comes down to careful observation
Right.
and knowing when to investigate further.
That makes sense. So we've covered the initial approach to physiologic and pathologic discharge.
Right.
What about those cases where surgical management is indicated?
Okay.
Can you give us a brief overview of what that might entail?
Of course, one of the most common procedures is a major duct excision, or MDE.
Right.
This involves removing the affected milk duct
Uh-huh.
to get rid of the source of the discharge.
That sounds pretty straightforward. Is it a complicated surgery?
Actually, it's considered a relatively minor procedure,
Right.
often done on an outpatient basis.
Right.
It usually just requires a small incision near the areola, and the surgeon carefully removes the involved duct.
So patients can usually go home the same day.
Yes, in most cases.
What's the recovery like?
And the recovery is typically quick with minimal discomfort.
That's good to know. Are there any other surgical options available if an MDE isn't appropriate?
Yes, another procedure that's sometimes used is a microdectomy.
Okay.
It's a more targeted approach where the surgeon removes only the specific section of the duct that's causing the problem.
So it's even less invasive than an MDE.
Precisely, microdectomy is often preferred for smaller lesions or those located close to the nipple.
Okay.
It's minimally invasive and patients tend to recover very quickly.
Are there situations where more extensive surgery might be needed?
Yes, there are, if the cause of the discharge is more widespread,
Okay.
such as a large papilloma,
Uh-huh.
or if there's any suspicion of malignancy.
Right.
Then a more extensive surgery, like a partial mastectomy, might be recommended.
So the extent of the surgery really depends on the individual case.
Exactly, and the surgeon will always carefully discuss the risks and benefits of each procedure with the patient
Right.
to determine the best course of action for their specific situation.
That makes sense. Earlier, we discussed galactography and ductoscopy as diagnostic tools.
Right.
Do they ever play a role in the surgical management of pathologic discharge?
They can in certain cases.
Okay.
For example, galactography can sometimes be used to guide the surgeon during an MDE.
Uh-huh.
By injecting contrast into the duct, the surgeon can more easily see the exact location of the problem area.
Right.
It's like a roadmap.
Interesting. And what about ductoscopy? Can it be used therapeutically?
Yes, sometimes.
Okay.
For instance, if a small papilloma is found during ductoscopy, the surgeon might be able to remove it through the ductoscope itself.
Oh, wow.
Avoiding the need for a separate incision, it's minimally invasive surgery within minimally invasive surgery.
That's pretty amazing. So
Yes.
we've got a range of surgical options to address pathologic discharge.
Right.
What happens after surgery? What kind of follow-up is typically required?
After any breast surgery, it's important for patients to have regular follow-up appointments with their surgeon or primary care physician.
Okay.
This allows the healthcare team to monitor the healing process,
Right.
check for any complications,
Uh-huh.
and address any questions or concerns the patient might have.
And I imagine the follow-up schedule might vary depending on the type of surgery that was done.
That's right. For less invasive procedures like MDE or microdectomy,
Uh-huh.
follow-up might involve a checkup a week or two after surgery,
Okay.
and then maybe another appointment a few months later.
Right.
For more extensive surgeries, follow-up is usually more frequent
Yeah.
and might include additional imaging to watch for any recurrence.
It's also probably a good idea for patients to be aware of any potential complications.
Yeah.
Even if it's a rare,
Yeah.
it's good to be informed.
Absolutely. Complications are generally uncommon,
Right.
but it's important for patients to know what to look out for. Some potential issues might include bleeding infection, delayed wound healing, or changes in the appearance or sensation of the breast.
So patients should feel empowered to contact their healthcare provider right away if they notice anything unusual.
Exactly.
Early detection is key.
Early detection and management of any complications can really make a difference in ensuring a smooth recovery.
Right.
Now, before we wrap up this discussion on surgical management, I think it's worth circling back to something we talked about earlier, the possibility of finding atypical cells or DCIS in papillomas.
Right.
If a papilloma is removed surgically, what happens next if those concerning cells are present?
That's an important point to clarify. What are the next steps if those types of cells are found?
Well, if atypical cells or DCIS are found on the biopsy,
Oh,
further treatment might be needed.
okay.
That could involve additional surgery, radiation therapy, or other treatments,
Yeah.
depending on the specific findings and the individual patient's situation.
So it's not always a clear-cut path even after the initial surgery.
That's right. But the good news is that with early detection and proper management, the prognosis for patients with these conditions is generally very good.
That's reassuring to hear. Now, I know we've been focusing heavily on surgical management for pathologic discharge.
Right.
But are there any non-surgical treatment options that might be appropriate in certain cases?
Yes, there are.
Okay.
For example, if the discharge is caused by ductectasia,
Yeah.
which we know is a benign condition,
Uh-huh.
conservative management might be all that's needed.
Okay.
This could include things like warm compresses, over-the-counter pain relievers, and simply keeping an eye on things.
So surgery isn't always the first line of defense.
Right.
Are there other scenarios where non-surgical options might be considered?
Yes. Sometimes medication can be used to manage the underlying cause of the discharge.
Uh-huh.
For instance, if hyperprolactinemia is a contributing factor,
Right.
medication to lower prolactin levels might be prescribed.
It sounds like the key is to individualize the treatment approach based on the patient's unique situation
Right.
and the underlying cause of the discharge.
And that brings us to the end of our in-depth look at surgical and non-surgical management for pathologic nipple discharge.
Okay.
We've covered a lot of ground,
Yeah.
but I hope you've gained a better understanding of the complexities and nuances
Yeah.
of this common clinical presentation.
I know I have. And it seems like the biggest takeaway here is the importance of a multidisciplinary approach.
Yes.
Collaboration between general practitioners, surgeons, radiologists, and other specialists
Right.
is crucial for providing comprehensive and compassionate care to patients with pathologic nipple discharge.
I couldn't agree more. And remember, clear communication with the patient, addressing their concerns and involving them in the decision-making process
Yeah.
are paramount to ensuring optimal outcomes.
So true.
Yeah.
A strong patient-physician relationship built on trust and open dialogue
Yeah.
is absolutely essential for navigating the diagnostic and treatment journey. It seems like we've pretty much exhausted our discussion on nipple discharge. As we wrap up our deep dive into nipple discharge,
Right.
I think it's helpful to take a step back and look at the big picture.
Yeah.
We've covered the different types, the red flags, the diagnostic workup,
Yeah.
and even the surgical and non-surgical management options.
Right.
It's been quite a journey.
It has, and I think one of the most important messages to take away is that
Yeah.
while nipple discharge can be a worrisome symptom for patients,
Right.
the vast majority of cases turn out to be benign.
That's reassuring to hear, but of course we can't get complacent, especially when those red flags are waving at us.
Absolutely. A systematic and thorough approach to evaluation is crucial. By
Yeah.
carefully considering the patient's history,
Right.
performing a detailed physical exam, and using the right diagnostic tests,
Uh-huh.
we can accurately differentiate between benign and pathologic discharge.
Yeah.
That's how we ensure our patients receive the most appropriate care.
And I think it's important to emphasize the role of shared decision-making in these cases.
Yeah.
Patients need to understand their options and be actively involved in making decisions,
Right.
especially when it comes to things like surgical interventions.
I completely agree. Every patient is unique, and their preferences and values should always be factored into the equation.
Right.
What might be the right choice for one person might not be the best fit for another.
Right.
Open communication and a collaborative approach are essential.
So for our fellow GPs out there listening to this deep dive,
Yeah.
what are the key takeaways they should keep in mind when a patient walks in with nipple discharge?
I'd say the most important thing is to avoid jumping to conclusions.
Okay.
Nipple discharge is a common symptom with a wide range of potential causes.
Right.
Take the time to listen to your patient,
Yeah.
ask the right questions, and do a thorough examination.
And don't forget those red flags.
Yeah.
Unilateral discharge, bloody discharge, spontaneous discharge,
Right.
discharge from a single duct, and any discharge associated with a breast mass or skin lesions, especially in women over 40.
Right.
These are the signs that should always prompt further investigation.
Exactly. And remember that age and sex matter when
Right.
you're assessing risk.
Sure.
Men with nipple discharge have a higher chance of malignancy,
Uh-huh.
so we need to have a lower threshold for investigation.
Right.
And for women, the risk of cancer increases as they get older.
When it comes to diagnostic testing,
Yeah.
tailor your approach based on the individual patient and your level of suspicion for physiologic discharge.
Okay.
A pregnancy test,
Uh-huh.
prolactin levels, and renal and thyroid function tests can help rule out underlying hormonal or systemic causes.
Right.
But for pathologic discharge, imaging is key,
Uh-huh.
starting with a combination of mammography and targeted breast ultrasound.
And don't hesitate to consider more specialized imaging,
Okay.
like breast MRI, galactography, or ductoscopy,
Yeah.
when the initial workup is inconclusive, or if you still have a strong clinical suspicion.
It seems like the treatment options run the gamut from conservative management for benign causes to surgical intervention for pathologic discharge.
They do, and the choice of treatment should always be made on an individual basis,
Yeah.
taking into account the patient's preferences,
Right.
the underlying cause, and the specific characteristics of the discharge.
We've covered a lot of ground today.
We have.
I think our listeners are walking away with a much deeper understanding of how to approach nipple discharge in their practice.
I hope so. Knowledge is power.
Yeah.
And by staying up to date on the latest research and best practices, we can all continue to provide the best possible care for our patients.
Well said. And that brings us to the end of our deep dive on nipple discharge. Until next time,
Great.
keep those brains curious and those hearts compassionate.